I'm Hyman Muss at the Lineberger Comprehensive Cancer Center at the University of North Carolina at Chapel Hill, and today we'll be talking about coming of age breast cancer in seniors. We all want to end up like this 100-year-old woman who still appears to have a great joy for life. And this is very relevant to breast cancer as well. Today, we're going to talk about cancer and aging, the epidemiology of breast cancer, comorbidity, and adjuvant therapy. Why do we need to care about older women and breast cancer? If we look at cancer, in the United States, it's a disease of aging. And if you look at these data, you'll see that more than half of all cancers are in patients 65 years and older. About 25% between 65 and 74, about a quarter between 75 and 84, and almost 10% after 85. And what's especially important is today, if you're 65 years old, you'll live an average of 20 more years, which a lot of us don't appreciate when we see a patient and perceive them as old if they're getting Medicare or Social Security. And even if you're 75, you're going to live about 12 years more on average, which is rather substantial. And as we've heard from other presenters, many of our cancers, such as triple-negative breast cancers, frequently relapse early. So that 75-year-old woman with a high-risk breast cancer who's going to live an average of 12 years really needs to be considered for the best of treatments. These are data from the SEER registry looking at breast cancer in the United States. And you can see that the average age of breast cancer is about 63. And if you look at the incidence, it increases dramatically with age. And if you look at mortality rates, most of the women who die of breast cancer in the United States are now 65 years and older. And frequently, when I talk with my own patients about cancer, they're shocked that cancer is a disease of older people. The average age of cancer is now about 67 in the United States. But when you look at TV, the media, people associate cancer with young people. Brian's song, a lot of the TV and media presentation of cancer, and even ads in our journals tend to depict people in middle age. But actually, the more common patient with breast cancer is in their 60s and 70s and much older than we perceive. In looking at older people with breast cancer, a key issue is whether the cancer is the patient's major illness. You frequently see a patient in your clinic and they're surrounded by families and they have ductal cancer in situ, and they're 75 and they have hypertension, mild dementia, and other problems. And everybody is worried about the breast cancer when the real issue are the patient's other illnesses. So it's very important in older people to figure out where the money is. What's the most important medical problem of the patient? And for example, here are two 80-year-old women. And should we treat them the same? One is Katharine Graham, who was editor of the Washington Post and who worked very late in life doing incredible things, being a great editor and a great media expert. And on the right is another 80-year-old patient who's in a nursing home, who has mild dementia, and who really can't function very well at all. Yet they're 80 and they might have the same breast cancer, but the issues are dramatically different as far as their management. The things that can help us are geriatric assessment of patients like this to define their function and especially their estimated survival. And in geriatric assessment, we look at the functional status of the patient. Can they dress? Can they walk? Can they cook? We look at comorbidity. What other illnesses do they have in addition to their cancer? We look at nutrition. Whereas everybody today wants to lose weight, in older people, weight loss is a bad thing. It leads to loss of muscle mass and actually shortens survival and poor function. Cognition. Can patients understand their treatment? What's the effect of our treatments on their mental status? Psychosocial factors and support. And polypharmacy. It's very common to see your older patients come into the clinic with numerous medications. They have numerous docs, and frequently a lot of the medications actually counteract each other and can be very, very hard for the patient to manage, as well as you to manage in your practice. These are data on comorbidity by age, and if we look at these data, we can see that comorbidity or coexisting illnesses increase dramatically with age. If you have a 70-year-old patient in the clinic, they have an average of 2 or 3 comorbid illnesses. And these are important because all these comorbid illnesses, chronic obstructive pulmonary disease, diabetes, high blood pressure, they all shorten your survival by themselves. So if you add breast cancer to that, it further interferes and competes with these other diseases for survival. And you can see by the time you get in your 80s, the average patient has 5 other significant illnesses affecting their survival. On the other hand, younger people in their 50s frequently have only 1 to 2 other serious illnesses. The other important thing is function. So if we look at function as far as survival, these are data in people 70 years and older taken out of the community, and it's looked at 5,000 patients in these databases and self-reported scoring of their function. And you can see if you looked at people who were dependent in bathing or who couldn't go shopping or walk several blocks, and you developed a score and looked at 2-year mortality, people with lots of functional loss, about a third of them, didn't survive 2 years, while people with excellent function were doing extremely well. So in addition to the comorbid illnesses, one needs to know the functional status of the patient from geriatric assessment. And what we're doing now at University of North Carolina, and what's been done by cooperative groups and is going on nationally, is developing brief geriatric assessment instruments that you can do in the clinic. And one of the pioneering instruments was developed by Hardy Huria at the City of Hope. And this is a self-administered instrument that takes about 30 minutes. And it's very important because it can identify those patients who are most vulnerable to treatment and where comorbidity and functional loss is key. We were able to use this brief instrument in our cooperative group and use it in clinical trials that were extremely complicated and collect data. And what's important is it's fast, it's accurate, and geriatricians today are rare species, and we need to be able to do something ourselves in our clinic to take care of these older patients. These are data on the cause of death of women with breast cancer who are 70 years and older. And what's really interesting is to look across the spectrum going from in situ cancer to patients with local disease who are node-negative patients, to patients who have positive nodes, and finally to patients with metastatic cancer. And you can see that even though all these groups of patients have breast cancer, that even people, for instance, with regional disease who are 70 or older, women with positive lymph nodes, the odds are they're going to die of one of their comorbid illnesses, their COPD, diabetes, stroke, heart disease, even though they have node-positive breast cancer. So it's very, very important to assess the function and coexisting illnesses of the patient in our clinics. An exciting thing that we're interested in at the Lineberger Cancer Center in Chapel Hill is looking at molecular markers of aging. So wouldn't it be great if we could come in and do a blood test and look at some factor in the blood that might predict those patients who are most likely to get myelosuppression or other problems? And here's an example of P16, which is actually a weak tumor suppressor gene, but whose gene expression goes up tenfold between ages 20 and 80. And this work done by Ned Sharpless at UNC gives us a very powerful potential tool for looking at patients with cancer. Patients who have low P16 expression tend to have either white cells or immune cells or kidney cells that have lots of reserve. They haven't aged as quickly, and they're likely to do well. While patients with high P16 levels are patients who are likely to have white cells that may not proliferate as well, that are more senescent. So this tool, measuring this gene, which we've been doing in T cells in patients' peripheral blood, may, in addition to geriatric assessment and comorbid illness, give us a molecular tool for estimating survival and for planning treatment. Now, in adjuvant treatment of breast cancer in older people and in younger people, our goal is cure, improving curability of the patients. And when we think about old elders, we need to realize that their recurrence risks are similar to younger patients when we adjust for stage, and that life expectancy is the issue. So when residents present me the patient, I like to hear not what the age of the patient is, but what's the estimated survival of the patient. Because at 75, if they have a lot of other illnesses, it might be 5 years. Whereas at 80, it might be 10 years if they're really very healthy, playing tennis and doing lots of things on their own. So life expectancy is the key to decision making. It's based on comorbidity, it's based on function, and healthy elders should be considered for the same treatments as younger patients. Undertreatment is a bad thing, and these are data from Quebec looking at patients who are older as a rule, but it's a wide net, and looking at distant disease-free survival of patients who conformed to simple St. Gallen guidelines like getting post-operative breast radiation or taking tamoxifen versus patients who didn't conform to simple guidelines. And you can see there's about a 20% difference in distant disease-free survival in patients just by following simple guidelines. So we've got to make sure that we don't lowball and undertreat our older patients. Now, you've heard great talks throughout these presentations on all types of breast cancer, but in older people, I like to think of three types of breast cancer. There's this huge group of patients who are ER positive and HER2 negative. And as you've heard before, these patients are probably very heterogeneous and divided into luminal A patients who have high ER expression, do well with endocrine therapy, and luminal B patients who are going to probably get more bang for the buck with chemotherapy and less efficacy with endocrine therapy. This is the largest group of older patients. Then we have the HER2 negative, ER negative, and PR negative patients, the triple negative patients, and they comprise about 15% of older patients as well. So this is a major issue for older as well as younger patients. And finally, we have the HER2 positive breast cancer patients. And if we look, this large group is about 70 to 80%, and you're more likely to see higher and greater degrees of estrogen receptor expression as patients get older. In triple negative, it seems to be about a consistent finding of about 15% of patients as they get older maintain triple negative status, and then HER2 positive patients are about 15% as well. The major question in lots of our older patients is what's the added value of chemotherapy in this large group of ER positive, HER2 negative patients? The data from the overview suggests that tamoxifen has been a winner, and this drug, which is now $10 for 3 months at Walmart, has probably saved more lives of postmenopausal women with breast cancer than probably any other drug, and probably that accounts for chemotherapy as well. So if we look at 5-year data on tamoxifen by age, you can see in the white bars that tamoxifen has a dramatic benefit for women as they get older, with a 50% reduction in the annual odds of recurrence and about a 40% reduction in the annual odds of dying of breast cancer, even in older women. So it's been a definitive winner. We now have aromatase inhibitors, and their role is being better and better defined as trials mature, but no matter what the design we see, aromatase inhibitors tend to reduce recurrence rates compared to tamoxifen by about 3 to 5%. There's only been a very small effect on survival, and one of the downsides is their cost. They're very costly medications, although they're very excellent medications. I find them very worthy of consideration in the elderly because of their toxicity profiles. Unlike tamoxifen, there are no increased risks of vascular events, endometrial cancer, and other toxicities. So I agree with the ASCO guidelines. They need to be considered for all postmenopausal women at some time in their course of treatment, and perhaps as initial treatment for many older patients. These are data from a study that was done by the NCIC in Canada, a large international cooperative group study that compared letrozole with placebo in women who had had 5 years of tamoxifen as adjuvant therapy. And what I've done here is carve out the patients 70 and older. And what's unique about this study is it compared letrozole with a placebo. And I picked some of the toxicities that we'd all be concerned about clinically and focused on older patients. So if we look at fatigue, it was identical in letrozole and placebo. If we looked at nausea, depression, and what we're all concerned about, arthralgia, myalgia, it was very similar in the letrozole and placebo groups. vaginal dryness, increased cholesterol, very similar. So actually we saw no differences in toxicities between a placebo and letrozole in older patients, which was somewhat reassuring about its toxicity profile and its use in this setting. Another tool that can be very helpful is Adjuvant Online, which I know many of you are familiar with. And this is a unique program because it does two things that many other programs do not have. One, it adds U.S. Census data on age. So when you put the age in, it adjusts for average life expectancy of the U.S. population. And the other thing, you can put in some estimate of comorbidity, coexisting illness. So what I've done here is I've plotted out a patient who's age 71, has a 2 centimeter grade 2 node positive breast cancer that's hormone receptor positive. And we're looking at 10-year survival data and the value of chemotherapy. So the first group is patients in perfect health. And if you look at that group of patients, even with no adjuvant therapy, but just surgery alone, 71% of those patients will survive 10 years. If you gave them tamoxifen for an AI, you'd increase it about 4% to 75%. There's a modest, if any, improvement with using drugs like CMF or AC for 4 cycles, and perhaps a better improvement for using more aggressive chemotherapy in this group, although I must caution that 80% is based on data that's really extrapolated from trials in younger women and really not verified in older people. So that's your perfect health patient. But look what happens if you use the same program and you put in poor health. Now, only a third of the patients are going to be alive at 10 years because of their comorbid illness having such an impact on survival. And here the benefits of all the therapies are less. So I think Adjuvant Online can give people help in looking at comorbidity, factoring in with age for the treatment decision. These are data using the Oncotype DX test from Genomic Health, recently published from the ATTACK trial by Dr. Dowson and colleagues. And these are data on patients who got tamoxifen or an AI and no chemotherapy. And what it shows is that even patients with 1 to 3 positive nodes who had very low recurrence scores tended to do very, very well and had very low probabilities of distant metastasis at 10 years. If you look at the green line, the patients with 4 or more nodes, there's a rather high risk of recurrence even with low recurrence scores. But I think the Oncotype DX, which factors in the degree of estrogen receptor expression, the grade of the tumor a little bit better than what we can do with light microscopy, is a great tool for a lot of these older patients in decision making. What about the triple negative older patients? We have data from the overview looking at relapse-free and overall survival in a very large group of patients. Now, most of these patients didn't have HER2 testing, but probably the majority, 70 to 80%, were triple negative. And if we look at these data and focus on the patients 50 to 69, and interestingly, about 60% of the patients in the overview in this age group were node positive, we can see a 6% absolute reduction in the risk of dying of breast cancer just with older chemotherapy like CMF or AC. So today with taxanes and other more aggressive therapies and hopefully new treatments, we're probably going to be doing much better than this. So it's very impressive. So older healthy patients with triple negative breast cancer should be treated with state-of-the-art chemotherapy. In the CLGB, we looked specifically at women over 65 in a clinical trial and randomized patients to either 6 cycles of CMF or AC, what we considered standard therapy, or the oral 5-FU prodrug capecitabine. And we were hoping that capecitabine, an oral drug, would be non-inferior in older patients, provide us with an excellent adjuvant approach to patients with breast cancer who were a little older and were getting to the clinic, and all the issues related to more aggressive chemotherapy and intravenous chemotherapy might be surmounted. But unfortunately, we found that standard therapy was better than capecitabine, and in the summary of the data, there were marked improvements that were highly significant in both relapse-free and overall survival, favoring standard chemotherapy with CMF or AC. One can see that the toxicity was less with capecitabine than standard therapy, but there were virtually no deaths from therapy in this entire randomized trial of over 600 patients, except in the capecitabine group, where 2 patients died of complications. And moreover, 92% of older patients tolerated standard chemotherapy with AC very well and got most of their doses, which was not true with CMF or capecitabine. In an unplanned subset analysis of the data, we confirmed that the big bang for the buck in these older patients was in patients with triple-negative breast cancer. So the 2 upper panels are in patients with receptor-positive tumors, and the panel on your left is relapse-free survival and right overall survival, and there are no difference in these groups now with a follow-up of about 2.5 years. But if we look at the patients with the triple-negative breast cancer, we can see marked improvement in this group of patients favoring standard chemotherapy, which is really underscoring the value of chemotherapy in older patients with triple-negative breast cancer. What about HER2-positive patients? We have data here from the summary of adjuvant trastuzumab trials showing the amazing added value of trastuzumab to chemotherapy in almost all studies that compared chemotherapy and trastuzumab to chemotherapy alone. And the study here is the BCIRG-006 study, which compared ACTH chemotherapy with chemotherapy that omitted anthracyclines, TCH chemotherapy, which consisted of docetaxel, carboplatin, and trastuzumab, and then the yellow line, which was chemotherapy with ACTH without trastuzumab. And one can see that the red and the blue lines, the trastuzumab-containing chemotherapy, are very similar. There's no significant differences between them, suggesting that one can give older patients non-anthracycline chemotherapy with trastuzumab and do very well. So this is an option since trastuzumab-related cardiotoxicity is age-related, and older people as a group are more likely to have difficulty with the drug. How do older women do with our more current chemotherapy regimens? In the CLGB, we explored the roles of more intensive versus less intensive chemotherapy in 6,600 patients. And in spite of our group and our feeling that we're not age biased, we only had 600 patients 65 years and older entered onto these node-positive trials over a 25-year period. In all of these trials, the more intensive chemotherapy was superior to the less intensive therapy. So it was a great place to look at the role of the therapy in older patients since we knew there were overall differences in treatment. And if you look at the left panel, the Kaplan-Meier curves in patients below 50, if one looks at the top curve, those are the people with more intensive therapy, and the lower curve, less intensive therapy. And you can see about a 5 to 10% or so improvement in overall survival, favoring more aggressive modern chemotherapy regimens. These data, though, supported the fact that the same benefits were seen in older patients. So in the right panel, we have patients 65 years and older, and one can see in the Kaplan-Meier curves the same degree of separation, the same benefits. What's a little bit different is if you look at the overall survival, is that in the older patients, you can see they're dying of other causes because overall by 20 years, and don't forget if you went on trial at 65 and 20 years you were 85, that many of those patients died of other non-breast cancer related causes. So it supports the fact that older patients, and they were in good condition on these clinical trials, who got state-of-the-art chemotherapy, derived similar benefits as younger patients. So in summary, what should be our approach to older patients with breast cancer? Well, if they're in good shape, first consider them for clinical trials. We need the data for better decision making, and consider standard treatments. If they're vulnerable and you've used the geriatric assessment, then you need to think carefully about the side effects of chemotherapy. A grade 1 or 2 neuropathy in a patient who's 70, who's living by herself, but who's a little shaky on her feet, and who now stumbles and falls, may put her in an extended care facility, and that would be a really downside of therapy. And for frail patients, probably chemotherapy and other aggressive treatments aren't indicated. Thank you very much for your attention.